Just a quick note before we start. If something in today's episode makes you think, that's me, I've put together 5 questions called the Not Done Yet Spark Assessment. It helps you see the thing that you keep circling and why you keep dismissing it. It'll take 5 minutes. I read every single one, and then I'll send you a personal voice response with my honest thoughts. The link is in the show notes. Now let's get to today's episode. Welcome to Not Done Yet, the podcast for midlife women who know deep down their story isn't finished. I'm your host, Rachel Perry, and here we're going to talk about what's really happening in this season of life, the identity shifts, the quiet questions, the courage it takes to listen to yourself again, what it actually looks like to step into what's next, and why our boobs are hitting our knees. If you've ever looked at your life and thought, wait, is this it? Girl, you're in the right place. Because midlife isn't the end of your story. It's the moment you start paying attention to it. So take a breath and let's talk about what's really going on and what you want to do with it. Because sister, you are not done yet. Hello, everyone. Welcome back to another episode of Not Done Yet. Okay, I know I say this at the beginning of every podcast, it's when we have guests, but for real, you guys are going to be so excited about this guest today because this woman we just met and we're instantly best friends.
Okay? We're total besties.
Yeah. And we just discovered. So well, let me introduce you first, and then we'll do a little background. So I'm going to read her bio. But this is Dr. Shannon Cothran. She's known for her outgoing, yes, would attest to that, and warm personality and her sharp clinical mind. So Dr. Cothran is a gynecologist, right? Like you consider yourself a gynecologist. Yeah. I mean,
I identify as a gynecologist.
Yeah. She grew up in Fairfax County and attended UVA. Okay, so all you local listeners, listen up because you're going to want to connect with her after this episode. She's a board certified gynecologist and her expertise is fully focused on meeting women's healthcare needs. Don't we need more of that? After residency, she began her successful career in private practice, where she worked for 15 years, taking care of women in all phases of life. She's attended numerous conferences, workshops, and learning events centered on providing effective menopause care. Yes, please. In 2024, she created Menostart to dedicate more time and attention to patients during perimenopause and menopause. And I can't tell you how excited I am to have you here on the show today. Shannon, welcome.
Thank you.
Oh my gosh.
I'm happy to be here. These are my favorite subjects.
Yeah, right. This is me too. What's so fun about this, you guys, is we were just chatting and our kids all go to the same high school, basically. And our boys they know each other. Yeah. And you guys who know me, I'm going to say, like, he was actually really nice to John Mark in high school. So that makes me really happy. You guys know how that is. So anyway, super excited to have this conversation with you today. And yeah. I said before we even hit record, like, I feel like this might become a series. So guys, if you love this, be sure to let us know, because I think this is what we need more of as women in peri and menopause. We need doctors who understand us and who don't dismiss us. And I'll share my story in a few minutes, but I would love to start with Menostart, which is what you have created and built. What you left your traditional private practice to start Menostart. And can you share how you came up with the name? Because I'm obsessed. And then what kind of led you to start Menostart? Right. When I say start anymore, I'm not sure.
I know. Yeah. We can say start as many times as possible. Yeah, it also is good for my brand. So it's perfect. Yeah. So, yes, private practice for 15 years, definitely feeling the burnout of that with 3 teenage kids and, working full time. Also getting to this phase myself, realizing there is a life beyond our fertility, which is good to know. And I know, shocking, right? But it can be amazing. And I wasn't feeling a lot of hope with my patients or myself, my friends, entering this phase. And luckily for us, their menopause started getting talked about a lot more celebrities getting into it, influencers, and really, I think, kind of turning around that anti-aging bias that kept a lot of people from talking about menopause, the angry old lady on the porch, which is not true. We live half of our lives in this phase. We have a lot to give, a lot of life. There is a lot of hope. There's a lot more therapeutics and kind of the turning around of the WHI study and the thinking about hormones, and just all of it happened at once, which was, good for me personally and professionally. So I was thinking about kind of doing a different kind of practice, one where I'm really able to talk to people more, longer, personalized care, really get into it, because these issues that we have affect our whole body, not just like a 15-minute annual. And I also started a fitness journey after my third baby, really learned a lot from that, and never could understand why the health and wellness industry and medicine were fighting each other. And so I was like, we should combine together because we're all looking for the same thing. So talked to my own trainer, and we decided to build a practice together, combining fitness and nutrition and medicine for midlife women's health.
I love that so much. And it's called Menostart.
Menostart. And so, like we were talking about before the podcast started, that 2 to 3 a.m., 2 to 4 a.m. wake up time that our brains do in this phase, which we don't really know why, but it's very universal and frustrating. But sometimes some creativity happens. And I was in that state, trying not to look at my phone so I could fall back asleep. And I was thinking, why pause? We're not ready to pause. We're ready to just get started on the next phase. And I was like, Menostart, that's what I should call my practice. So I was thinking of like pressing the triangle, pressing start,
Yes. I love that so much because, as you know, my podcast is not done yet. And I truly believe that. And I think this is a narrative that we need to change because like I said earlier, society is just sort of shelving us. It can feel that way anyway. Mm-hmm. And that's not true. I mean, we're at our best. I mean, granted, our bodies might not be feeling at our best, but for sure, I think this is a beginning for many of us, right? Because we've been so focused on everybody else. My story is basically that I was in my early 40s and I went to my doctor and I said, my hair is falling out. Mm-hmm. And my anxiety is especially high. Now I'm on Zoloft. Okay. I have been since I had my son, not because of my son, but anyway, that's another story. And she looked at me and she goes, okay, we'll check your thyroid. And I was like, okay. And she's older than me. So it's not as if she hadn't been through, she was anyway. Then several years later, I think I was 48. I said, okay, my hair is still falling out and my anxiety is insane. She said, show me a 40-something-year-old woman who doesn't have anxiety. And I was like, okay. She said, let's just up your Zoloft. And I was like, well, can we check my hormones? And she said, are you still having your period? And I said, yes. And she was like, then we're not going to do hormones because I don't give hormones. I don't prescribe hormones unless you're done with your period. And I was like, okay. And she said, the problem is we need to up your Zoloft. So let's bump up your Zoloft. I'm on 50 milligrams. She was like, let's bump up your Zoloft. And I was like, I don't want to do that. And she goes, well, that's the solution. And then she said, and you need to lose weight. And I was like, I know. I've been trying. Every time I come in, I tell you, I can't lose weight. So all these massive signs, I ended up leaving crying that day because I cried in front of her. And a lot of the ladies who are listening have probably heard this story if you're local. I was crying because she was shaming me for my weight gain, shaming me for it, then announced it to the nurse. And those walls are thin. Yeah. So I just felt so embarrassed. And it was at that point that I left. I was like, and she had delivered all 3 of my kids. So I felt some sort of loyalty to her. She knew my story. She knew all the things. But my husband said to me, which was shocking. He said this. He was like, Rachel, how long are you going to choose loyalty to her over your self-worth? Like, oh. Okay. So it was at that point that I was like, okay, well, MIDI Health, I'd heard all these great things about how they prescribe hormones and whatever. And I did that. And then now I'm somewhere else. But it was such a revelation for a doctor to listen to what I was saying and be like, oh, yeah, we're going to prescribe estrogen and progesterone for you. And it changed my life. So hearing what you do and that you started this business solely to help women in this stage of life feel seen, heard, and understood and help them navigate this weird, weird stage of life is massive. And so I put some questions out there about some of the weird things that happen to people during perimenopause. Okay. And menopause, I guess. I don't know. Do they
Yeah,
happen?
menopause still is a thing. So they are different phases and they have different treatment strategies. And I think that that's something that can be confusing now that everyone's getting hormones.
Right.
You're like, my neighbor feels amazing and I'm on this hormone. It's not helping. It's like, well, she's 52 and you're 42.
Right.
You may need different things.
Right.
So there's still a lot of personalization that needs to happen. And, the kind of private equity based corporate practices are just not set up for that.
Right. Right. This was
and I have a lot of compassion for your GYN too, because I know how that feels. When I was at Capital Women's Care, and they're great doctors. Everybody's, well trained and really good intentions. But, I had a very long waiting list, but they were always coming to me and being like, you're our lowest biller because you're taking too long, and then they would make my patients get a handout before the annual exam that said, you're only allowed to ask Dr. Cothran one question. I know. Can you imagine? Because I was, always behind because I didn't believe that you could do all this in 15 minutes. But that was the push, So when I would see menopause symptoms on my schedule, I'd get so stressed because I knew like, well, this is going to put the whole day behind. And so then I'm sure I would take that stress into the visit, and just be like invalidating because you're just trying to get through the schedule that you have to get through. So it's not good for the doctor or the patient, to have that, especially this type of, there now identified 70 symptoms associated with perimenopause.
Can we talk about that? Let's talk about some of those. I mean, we don't have to go through the whole line, but I was talking to a friend the other night and she said, I have been having this weird, it feels like I have water in my ear. And she was like, I had it for so long. I finally went to the doctor and they did everything. My hearing is great, everything. And the doctor said it could be associated with perimenopause.
Yeah.
What? So is basically every weird thing, do we generally, it's probably perimenopause?
I think that's why it's important to have a professional talk to, because some things aren't perimenopause, right? And you do want to rule out any dangerous things, but it is a head to toe. I did a head to toe talk because it affects hair, skin, ears, all of those things, your heart, your lung capacity, your joints, your skin, right? Then obviously the pelvic things, the vagina.
Yeah.
All the way. Yeah. My favorite.
Yes. All the things. And so, you have to make sure it's not something dangerous. And then it's probably this change you're going through. But the messaging that gets lost is the hope message. Like, you're going to get through this. We have some therapeutic options, like what you finally found. And to validate is so important. And to say to the people like, it's going to feel like your body is going crazy, because it kind of is, but you're going to come out on the other side, and, we're here with you to partner. Let's get through this, So that is what I think we're not messaging enough, is the hope. And I think that's in that moment. And I know that I'm not alone. And that's why I'm sharing this story, is because there is that feeling of like, there's something wrong with me and I'm going through this all alone. And like you said earlier, there is more talk about it. It's not, like for our parents, our moms,
Right.
they just had to suffer through it. But I do think, I went to the doctor. I'm just now realizing this. I went to the doctor because I was having heart palpitations.
Mm-hmm.
And everything was fine. And now I'm like, oh, wait, maybe that was also related. Like
Yes.
all these things.
Yeah.
What is the weirdest symptom that you have had someone come to you with, or that you have, or that you know of that would be related probably to perimenopause, menopause?
Yeah.
I don't know.
I had a patient who was getting hot flashes, but only below the waist. Like only her legs were getting sweaty. I was like,
oh my God.
I don't know. But it was a hot flash. That's just how her body was doing the hot flash. So that was an unusual one. Usually the hot flash
is all over.
Yeah.
And what should someone do if they're listening, and even if they're not local, let's say,
mm-hmm.
how do we know? I know the answer is go to the doctor, but like when is HRT a good option?
So perimenopause, I'll talk about perimenopause and then menopause.
Right. Yeah.
So HRT just means hormone replacement, and it just is giving, in our case, as women, it's estrogen and progesterone, and then sometimes testosterone. Those are all the sex hormones. That's what we call it. And perimenopause, usually the ovary is still working, still making those hormones. That's where those hormones come from in us. And the problem is that as opposed to our 20s and 30s, in the 40s, usually 7 to 10 years before menopause, with the average age of menopause being 51. So it can be early 40s to late 40s. The ovary starts going kind of crazy, and you get these huge fluctuations in hormones. A couple months in a row, you may be fine, and then you just have like a super high estrogen month. And we don't really know why that's happening. It's very similar to puberty, which we all are, a lot of us, I should say, if we have female children, are also going through that fun. I don't know why God did that, like making puberty and perimenopause at the same time, but
that's such a good point.
It's good times, right? But puberty is celebrated, like, oh, yay, you're getting a woman body,
mm-hmm.
It's celebrated in society, all of those things, it's kind of like expected that you're going to have mood changes and other body issues. Perimenopause, we're supposed to just, not talk about it. The body changes aren't really celebrated. But it's equally as frustrating. So in that phase, it's more of stabilizing the hormones than replacing them, because you have hormones. They're just kind of in an unstable situation. And it depends a lot on what your fertility plans are, and, do you need contraception? How are your periods? Do you still have a uterus? All of that can affect our decision making on what type of hormones to give. So in perimenopause, a lot of times I'm trying to suppress the ovarian hormones because they're going crazy, and then replace them in a more stable, steady state. And then after menopause, estrogen and progesterone are gone. Like they just precipitously drop. And that's where you need the replacement. So it's kind of a different strategy.
Right.
So anybody that is having any of the symptoms that we're talking about and kind of alluding to is a candidate for hormone replacement or menopause hormone therapy. MHT was a term going around for a while.
Okay. So something that I've noticed, and I've been taking, like I said, estrogen and progesterone for probably a year and a half now. Mm-hmm. And I've noticed recently that I'm sharing this, is not so that I have my own doctor's appointment with you. It's because I think other people are probably experiencing other things like this. Is it normal to all of a sudden, after you've been on it a while, like through perimenopause, to then be like, wait, I'm actually having hot flashes now, or my joints are hurting more than they were, or my anxiety has increased? Is that normal while you are on hormones? Because your hormones are changing.
Right. Still. And sometimes it involves what we need, and so I do find in my practice that perimenopause seems to be more distressing because the symptoms are more kind of acute and, I guess not as straightforward. And people have had that situation that you had where they're dismissed, not validated, made to feel like guilty about their body changing. And we don't like that. So sometimes we don't really have the language as much to talk about it as we do in menopause. But definitely it can be something that is changing, as your ovarian situation is changing.
Right.
It's called the ovarian situation.
Of course it's a situation. Yeah. Of course it's a situation.
The ovaries having a situation. So
that's so funny.
Yeah.
So I know that there was a lot of negativity and hormone replacements therapy is not a good idea. And that's changed, right?
The data hasn't changed, but the thinking has changed, really. So a lot of things in the past 25 years with HRT has happened. So in the 1930s, estrogen was identified as a hormone and isolated and, used for contraception and all of those things. And then a book was written without any randomized controlled trial or really good evidence called Feminine Forever or something like that, where, we were going to fix the grouchy old menopause lady. She was going to be nice and happy and want to have sex. And, of course, everybody wants, all the men were happy with that model of person. And so they just started giving everyone estrogen that was in menopause. Without any studies really. And then doing that fixed a lot of the menopause symptoms, but without progesterone was causing uterine cancer. So then in the 70s, they realized you can't just give estrogen on its own. You need progesterone to protect the uterus. Unless you don't have a uterus, you need estrogen and progesterone. But because of that, there was some reluctance then to take, the estrogen because people associated it with cancer. But the issue is fixed with progesterone. And then the birth control pill got, easier and more acceptable, and people were taking hormones, really revolutionized women being able to go to work, control their family size, a lot of good things from that happening in the 60s and 70s. And I think that's, part of why our generation, our moms were the first women in society that could control that part of their life.
Right.
No one was really focusing on menopause then. They were just like, oh, this is new. And we're kind of the daughters of that and realizing like, great, I'm happy I could control how many babies I'm going to have. But now what about after the babies?
Right.
In the 80s and 90s, they found that women were getting heart attacks about 10 years later than men. So they figured that estrogen was protective on the heart, and that was actually good. And that once we got into menopause, we're getting heart disease and strokes, all the things men get. And so there is a push from the drug companies and women's health providers that, menopause is a disease and everybody should be on estrogen and progesterone, not only to stay feminine forever, but to protect the heart and other, health reasons. And then to prove this, they did the WHI study. This was a randomized controlled trial. It's still going on, but it was supposed to prove that HRT was awesome and everybody should be on it forever.
Mm-hmm. Mm-hmm.
Unfortunately, the study design was really flawed. It was older women who had already been in menopause for a while, already had heart disease in a lot of cases. And it was actually stopped early because they found an increase in heart attack and stroke. And in 2002, that data came out, went to the media, and everyone's like, hormones are actually harmful. There's increased risk of heart attack and stroke. There was a slight increased risk in breast cancer, but the media was like, it also causes breast cancer. And so everybody at that point, and I was in med school, so I remember, stopped taking hormones.
Mm-hmm.
24 years. I can't do math. I'm a gynecologist.
Me either. Yeah.
I'm a vagina doctor, not a math doctor. So whatever it is, 20-ish years later, kind of the pendulum is swung back. everyone looked at that data again and was like, actually, that's not what the findings showed. You know, I think women our age were kind of advocating more for ourselves, like especially the millennials, like a little bit younger than me. They are not accepting women's suffering as the norm. And, you know, let's relook at the data. And it didn't actually show that increased risk as much as we thought. And so hormones are kind of having a resurgence. And it's still not safe for everybody.
Right. Right.
That's why you do have to have, you know, people that understand that and who you are, really, you know, take your blood pressure and all those things, which is part of my kind of reluctance about the telehealth only options. I
Yes.
think it's nice to have an in-person, you know, we have an exam room, all the things. But it's really opened up access to these medicines. And then recently, when that WHI study came out in 2002, they put a black box on all estrogen and products. And that's just the FDA warning people, like, you know, this drug could be dangerous. So you have your estrogen that's in your whole body, and then you just have vaginal estrogen. Two different types, different safety mechanisms. The amount of vaginal estrogen we use doesn't get into the rest of our body, but is very good for sexual health issues and urinary issues. And so we've always been trying to get the black box off of that estrogen because it's safe. Even breast cancer survivors, everybody can take that. And so the menopause influencer advocates have been fighting for that for a long time. And, you know, this administration was like, great, we're going to do that. And we were so excited. But then they took the black box off all estrogen. So it's kind of like, oh, okay. Not exactly what we were thinking. But it's interesting. It's opened up the conversation, you know, again, about the safety and who should be on HRT and when. But it's very nuanced. There's new data coming out, but it's still kind of a frontier, honestly.
Yeah. Well, that actually brings me to my next question. Who is a good candidate for HRT and who might not be?
So let me answer it this way. The estrogen can cause, you know, it's thrombogenic or it can cause blood clots. And so we know that for pregnancy, you know, people getting their period, people being on birth control, people in menopause. So we call estrogen a thrombogenic molecule, can promote clots. And so anybody that has a clot or a risk of a clot, you know, heart attacks and strokes are diseases of clotting, you know, then they should not take estrogen. So if you've had a heart attack, if you have a clotting disorder, you know, if you've had a stroke, those people are not candidates for estrogen. Now that we have, you know, a lot of different formulations, we know that estrogen that's absorbed through the skin or transdermal, the metabolite of that is less thrombogenic than oral estrogen. And so that's why everyone's like, we'll do the patch, we'll do the creams.
Okay.
And so in somebody that doesn't have a heart attack history, but has hypertension or diabetes, you know, an increased risk, but not having the event yet, in those people, you know, having the transdermal option has been nice because it kind of expands who it can be safely used for. But because of that, I think everybody, you know, MIDI, all those guys are just saying all menopause people should be on a patch, which isn't totally true, but that's why there's the patch shortage. Yeah.
Yes. I will tell you, in my experience, while I was so relieved and happy that I felt seen and heard, like it was such a relief, I started getting a little bit concerned when the person that I saw changed and I got on the call. This was the last time I met with them. And I think she was a nurse practitioner and she was like, okay, so we're going to give you the testosterone. And I was like, what? I'm sorry, what? And she was like, yeah, we're just going to give you the cream. It said, and I was like, I'm not on that. Like my levels looked okay, like maybe slightly low, but low average, I guess. And she was like, well, we'll just try it and see. And I was
feel
like,
like
I
they were
don't feel like that's a,
pushing
that's a
hormone
hormone
on
that
you.
you just like,
Yeah.
yeah. I was like, oh,
Yeah.
and I never did it. Because then I actually went to Capital Women's Care, and the doctor, she was like, no, I do not prescribe. I do not do testosterone. Estrogen and progesterone, yes, not testosterone. I was like, okay. Now, I
Yeah.
wish I'd asked why.
Yeah.
So
So
can I ask you that?
testosterone's a
Like,
whole
because I
nother,
okay.
world. And traditionally GYN, we're not doing testosterone for women that much. Some people, I guess, actually, no, I never in residency or early in my practice heard of giving women testosterone replacement. But it's really been,
It was just like a cream, she said.
Yeah,
She said it was
cream.
the
So
cream.
testosterone is a different type of medication. It does have pills, but they're not available in the US. So it's transdermal or an injection or these pellets. So there is good data. There's actually a study that shows that testosterone in women can increase libido. So sexual health,
I
metabolism,
mean,
hot
yeah.
flashes, irregular periods, those are the big four like bad symptoms of perimenopause, and menopause. So of course, sexual health, there's tons of incentive to figure out how to make us want to do it more, right? So
I mean, I would love that.
so that's the only actual data for testosterone in women is for libido. But there are a lot of influencers and I'm going to call them advocates because they are advocating for women
Yeah,
and some
for sure.
observational studies and kind of suggestions that testosterone in women can also help with the joint pain, increasing muscle mass. We know it does that in men and women. And then helping with cognitive and some mood issues, also that have been shown on testosterone. Um, PBS did a documentary called The M Factor a couple years ago. It came out, and
Yes.
when you watch that, you're like, maybe I should be on testosterone, because they make it sound like that,
Yeah.
it changed everybody's life, made them get back to who they were, all of that. It's hard to differentiate if that's testosterone or also the estrogen progesterone combination. The data, when you look at the literature, doesn't show as strong of a case for that with testosterone, but it's pretty safe at the doses that we're using. So if people want to try it, I'm very open to that. And that's one where I do recommend the labs. And I do have a patient whose testosterone was 0, and she's an elite athlete and wasn't feeling strong. And, we restarted testosterone and she feels great. So I think it does help people in certain situations, but I don't think everybody who's, 40 to 60, we should be like, here's your bag of hormones, like, have a nice day. Like,
Right. Right. So
yeah, I was just going to say pellets are a thing
off.
that testosterone pellets, a lot of pharmacies and some doctors are using. It's not recommended really by the Menopause Society or the American College of OBGYN. The issue is that you get these super physiologic doses, very, very high doses. And people feel amazing on it at first. Like, I could lift up a car, because it's just like steroids back in the day. But it can cause oh gosh, here's my perimenopause. Virilization. There we go. Where, you get voice deepening, male pattern hair loss and growth. It can cause clitoromegaly and, which maybe sounds good at first to have a bigger clitoris, but it actually causes pain. It's not like happy big clitoris. It's sad big clitoris,
Right.
where people even sometimes need surgery. Yeah. But luckily, another modern medicine phenomenon that's happening that's really helping us learn about testosterone and hormones in people's bodies as they age is trans medicine. And some of the people with pellets are having levels the same as someone like a trans man so unless you're wanting to be more masculine, those levels of testosterone blood levels aren't good.
Right. Oh my
Yeah.
gosh. Yeah, no, thank you. Like I already struggle enough to feeling attractive
Yes.
and desirable and all of that with all the things that are changing, my boobs reaching my knees, like, the thicker belly, and it taking forever, you know what I'm
Yes.
saying? Just there. So
Yeah,
that's
not
really
on the
good
doses
information.
we're using here, you don't get that, and all of those things are
Right.
reversible except for the voice changes. So if you start getting acne or hair growth
Right.
and you stop the testosterone,
Right.
it gets better.
Right. So if a woman is listening, and listen, we have only like touched the
Yeah.
tip of the iceberg in this conversation. So I do think that we need to, if you're okay with that, have more. And if you're listening and you would like us to have Shannon back on, then let us know and let us know what questions you would like answers to. But if a woman is listening, well, if someone is listening to this and is like, wait a second, I see me, like I feel this on so many levels in everything that we've talked about, and she's not on HRT, or maybe she is, what should she do first?
Do you mean like which therapeutic should you take first?
Like if someone's probably someone who isn't on hormones, but if someone's like, okay, yes,
Yeah.
I feel all this. I have the hair loss. I have the anxiety. I have the weirdness. I have the hot flashes on the bottom half of my body. What should she do?
Good callback. Yeah, honestly, the first step I would say is a consult. It's very consultative
Yeah.
because you got to talk about your medical history, your OB history, birth trauma increases the chance that you're going to have worse menopause symptoms, which is very interesting to me how our body processes trauma. We don't talk about birth trauma enough. Your family history, all of those things, you need to get a whole picture before we can say you need this, hormone X and Y. And so the first step is going to be to find somebody where you feel comfortable having a consultation about these issues. That's number one.
What are some questions, in her 5 minutes? If you're local, clearly you need to, and I will give you all the information on Menostart, but what are some questions that will get her better care?
That's a good question. Like how to navigate this medical system in this phase of life is kind of what I'm hearing you ask. I mean, gosh, Rachel, it's tough. I'm not going to lie. It's just tough. One thing that I think that can help is to make a separate consult visit, not try to do it at your annual because the system's just not designed for that, and there's lots of, resources online and things about what different perimenopause symptoms can be. And if you kind of think of a list, like which one is the most distressing to me right now, you're not going to fix every single symptom in one visit. And then how do you feel about medicine? Some people want a bag of pills at the end of the visit. Some people don't. They want to think about more holistic options or natural options. And so kind of figure out what the goal is of the question. If you're like, I'm having such terrible hot flashes, I cannot sleep and it's affecting my work performance. I'm grouchy all the time because I'm so tired. I don't know if this is my anxiety or sleep or which one, and that's the main issue that I want to talk about today. I think that could really help. But sometimes it's hard to know what the issue is until you have that conversation. And
yeah. And actually that is something, all the symptoms that I was having before with I would wake up from sleeping, and my lower back was so painful. I couldn't bend down to touch my toe. I mean, I can't bend down to touch my toes now, but it wasn't flexibility, that it was like, I was just in so much pain. I'm like, do we need another bed? We just got another mattress. Like what is happening? And it wasn't until I did more research that I discovered that in fact is perimenopause. My shoulder hurt. My shoulder was so painful and I thought it was because I was sleeping on it.
Hormones.
Nope.
Yeah.
There's so many things that are a result of this that we don't have to suffer through. And I think that's something that I'm hearing from you is
Yes,
like, there is hope.
there is hope. And you
There's so much hope.
deserve to feel good, and you deserve to invest that
Yes.
time. So that's why we designed a 6-month program, because sometimes that's how long it takes. It's not going to be just one appointment.
Right.
It's kind of a program that people
Right.
need. And I think as women, and moms and career people and daughters, all the other roles, wives that we are, we forget that we also
Mhm.
deserve some time, and that investing now is going to help us be better at all of those things. So
Yes. So that brings me to my next question. Thanks
we're
for
like so in
cueing me
sync.
there. I know. I love it. I love it. I'm like, I want you to be
No,
my doctor, but is
not
that
weird for
weird? Because
me.
now that we're really,
Yeah.
but not weird for me. You can look at my
I'll
vagina.
show
I don't
you
care.
mine if you show
At
me
this
yours.
point, it's so funny. How does Menostart work for women
Yeah.
who want to work with you specifically? So you mentioned the 6-month program. Can you tell us a
So
little
I'm
bit
the
about
only
that?
physician here right now. So when you make an appointment, I'm who you're going to see. I don't have like 10 closet NPs that are going to come out and see you. It's just me. And you go to the website, www.menostart.com. It's MENO dash START. The dash is for hot flash. One of my friends gave me that one. Like, love it. I know.
I
People are
love
so
that.
creative. And then you can schedule a
So
free
good.
15-minute consult, which is a call, and we can see if it's a good fit. I don't take insurance. So we used to call it concierge. Now we're calling it direct to patient care, which I like that better. But the whole
Mhm.
program's less than your deductible in a lot of instances. And you get such better
Wow.
one-on-one. I give you my cell phone number. I give you my email, you know, direct access. We have openings, and we have time
That's
to really
huge.
get into it, which is nice. And then any meds, imaging, labs, we all try to use the insurance for those, because we do want to work in the system that we're in. And then the program
Right.
includes
Right. Right.
fitness and nutrition consult as well, and then up to 2 sessions a week with the trainer or a group class. So that part is nice for the community that we are talking about. The group class is really fun. And, even elite athlete to someone who's never been in a gym, it's private. It's, a place where you can
Mhm.
just be Rachel. You're not John Mark's mom, or in my case, Dr. Cothran,
Right.
just Shannon. And it's like, it's kind of the only place that I have like that.
Yeah. And it's
Yes.
such a vulnerable time, I think, for us as women. And being able to see
Hmm.
someone who totally gets it, where it's the whole picture. It's not
Right.
just like, let me look at your vagina. It's the
Yeah.
whole picture. And I think that's what's so appealing to me. So
Yeah.
it is out of network, but that gives you more, I would
More
imagine,
flexible.
more
Absolutely.
flexibility and more
I
ability to
could
do
do
things.
virtual. I can do a
Yeah.
phone
And I
call while
love
you're stuck in traffic on the Beltway, because I don't have to bill every
that.
visit. It's just taken care of.
Right.
But we can
Yeah.
submit HSA and FSA too. And I don't charge for super bills or
Okay,
anything.
cool.
I want it to be easy.
Okay.
Yeah.
Yes, I love that so much. I love that so much. So, wrapping this up, what's one thing that you want every woman listening to walk away knowing today?
I want every woman in midlife to know, no matter what your path was to get to this, self in this body right now, that all of those things that built you, some of them are good, some of them are bad, but they all made who you are now. And we can make who you are going to be in the next 4 decades even better. So it's not an end. Like you said, we're not done. We have a lot of things to do,
No, we're
but
not.
we did cool things. We grew people in our bodies. We were in college before social media. Like, thank God, none of that's online.
Thank
We built
goodness.
careers.
Yeah.
Like, a lot of cool, awesome things got us to this place, but there's a lot to look forward to.
I love that so much. I love ending on that note. All of the information for those of you who are local or who, are still want to talk to her and make it a consult. I don't know how it works, but I'll put all the information down there. We are talking about, Shannon and I are talking about doing things together in person. We can speak about that. Yeah. So again, be on the lookout for all of that information. Shannon, thank you so much for being here.
Yeah.
Oh my gosh, this is so fun. And again, if you guys want us to do a series, if Shannon would be up for that, like I'm down with it, we'll do it. So let us know. Thank you for being here. And you guys share this with a friend who is also in midlife, because this is what we need to do. We need to support one another, share all the things. This was a weird conversation, right? These are conversations well, not actually weird, but these are conversations that we don't want to have because we feel embarrassed or whatever. We're here to make sure we'll ask all the uncomfortable questions. And for my son who is editing this podcast, sorry, honey. All right, guys, thanks so much for being here. I can't wait to see you next week for another episode of Not Done Yet.